Would you board a flight with a low fuel indicator light warning?
I know I wouldn't be on that plane.
Would you go into surgery knowing that you don't have enough blood capacity to make it to your final destination? Many people do it every day.
Even still now, the default thought in medicine is blood is a good thing. If somebody's bleeding or somebody has blood loss, giving a blood transfusion is a good thing.
I had witnessed several blood reactions, and so I just always sort of questioned this might not be as simple as everybody's making it out to be.
In this episode, we are revealing a centuries-old myth in medicine and the practice that is finally unraveling it. Hey guys, it's great to have you back. Thanks for joining us on Let's Talk PDM. Today I have two wonderful guests that I'd like to introduce you to. First of all, Joshua Ozawa-Morriello. You are a nurse practitioner. He specializes in many things, one of them being patient blood management. He's a leader and driver in this field. Also, Kelly Martin. She works in quality and she leads patient blood management for her hospital organization. She kind of sits the same as I do. And we're talking about dispelling the myths around blood and blood transfusion and the appropriateness in medical practice today. Thanks, Kelly and Josh, for joining me today.
Thanks for having us.
Thank you.
First of all, Josh, if you don't mind starting us out, in your experience with medicine, what would you say is the conventional thinking about transfusions in medicine?
Sure. Let's start back towards World War I era. Blood transfusions became very prevalent around World War I when there was a lot of war going on around the world. These soldiers were in active combat. People in the United States, elsewhere, mainly the United States, as it was one of the bigger countries at the time, started these blood drives, right? So telling people, the public, to say, give your blood to the army, give your blood to the military so that you can help them. Once that thought was placed in people's minds, that kind of stuck around through medicine's history as well. So as you saw past World War I into World War II, even past World War II, all the way to through the 1970s and 80s is really when the blood drive and telling people to give blood was very, very important. So it ingrained itself in medicine there as well. Transfusion became the typical to treat blood loss, right? People were losing blood in the hospital, you would give a blood transfusion. People were losing blood because of an accident, you would give a blood transfusion. And as this kept going and going and going, it evolved eventually up until the AIDS epidemic, where people started to question this. And even still now, the default thought in medicine is blood is a good thing. If you're a person and you want to give blood, you're doing a good thing for those people. And as such, clinicians follow suit. If somebody's bleeding or somebody has blood loss, giving a blood transfusion is a good thing. And part of what we do as nurse practitioners, nurses in the patient blood management field is trying to reframe that thinking as the body as its own organ. Maybe blood transfusion isn't such a good thing, for example.
Yeah. Kelly, do you find the same?
I do. Josh has a great historical background on that. Josh and I are switching roles where he's the old person now, and I'm going to come in a little more recently. Nursing is my second career. My first career, I worked in public relations, and I worked for a national blood servicing center. And this was back in the mid to late 80s when we did have concerns about the safety of blood and the potential spread of infectious disease. And that was back in a time when I think the thought about blood was like, oh, their hemoglobin's 10, give 2 units. That was kind of like the standard. And then I became a nurse during that time as well. And when I was hanging blood, like, oh, that's kind of weird. We're like putting this another person into them kind of thing. And it was just so I was always a little like, how is this? Had witnessed several blood reactions. And so I just always sort of questioned what would I do if I needed a blood transfusion? And this might not be as simple as everybody's making it out to be. I then went on with many years of other kinds of nursing until recently. I became part of blood management in my organization about 7 years ago. And it was a position that they opened up because of all of the literature that was coming out. And they just felt that it was an area that needed to be investigated. So we sort of started from scratch here.
You told me how you, Kelly, started to doubt it and where your doubts started to come up. Josh, how about you? When did you start thinking, oh, But conventional method or what we're being taught isn't necessarily like, I doubt it.
Starting at a very young age, I was kind of ingrained in patient blood management. My generational legacy is partly there. My mother being one of the major important people in patient blood management. So I kind of grew up around it. When I was in nursing school, I saw both sides of this, right? So growing up with patient blood management and just these thoughts of, hey, blood transfusions aren't the best first option, that was always my main perspective, right? So when I went to nursing school and I went to work in the hospital, and I went to work in these outpatient settings, and transfusion was the main thing, I never had that main viewpoint. So my perspective of things was more so much more on the statistical side, right? Looking at these transfusions when they occurred, what were the good things about it? What were the bad things about it? I had a specific patient who's kind of lived in the hemoglobin range of 5 to 6, and they were totally fine. And every time that hemoglobin dipped just a little bit below 5, he would go out to the hospital. He would immediately go to the ER. They would tell him, "Oh, it's time to give a blood transfusion because your hemoglobin is so low." Looking at that number, he was totally fine, right? When they don't have any symptoms. And when seeing that patient being there at totally fine at 4 and 5 and 6, historically, he had to explain himself over and over and over again to these clinicians that it wasn't the best thing. So I thought, if he's okay there as well, what about all of these other people? These people that live in the 7 to 8 range, these people, even if they're acute blood loss, right? They live just a little bit below normal and they're still getting transfused. What's really the indication there? It makes you think much more.
Yeah. So, what do you think is changing clinical minds today?
When you look at the actual clinical basis of transfusion, and this is much more on the clinician side than it is on the public side. So your people don't usually see this, right? You see these transfusions that are being given, and then you look at the outcome later. People who tend to get transfused because of anemia, acute blood loss, it's maybe a different story. But again, this is the band-aid approach, is what I like to call it. You give a transfusion, the number comes up for a little bit. That makes people happy. That makes patients happy. That makes clinicians happy. Then when this patient goes home or this patient goes to rehab or they're back with their family and they start feeling worse again, they'll go back for their follow-up visit and then their number's back down to where it was. When people see that on a larger scale, that changes your mind a little bit about giving that transfusion, right? You're thinking more in the process of things and wanting to fix the underlying issue. And patients should feel that way too. It's, if you're getting a transfusion, what's really the reason behind it? Work with your clinician to say, is this really necessary? It's more, that's the question that clinicians are trying to get patients to ask, as well as they need to hear themselves as well, as patient blood management gets bigger and bigger around the country and the world.
Kelly, what do you find effective in your organization to drive it?
Well, working in quality improvement, we always use data to support our message, right? So having the support of executive leadership, I think, is like really key. If your executive leadership is not on board with any of this, you're going to have you're pedaling up a stream, right? And when you show your clinicians the literature, the evidence-based literature, and the outcomes and the data, it's kind of hard for them not to buy into it because there it is. Clinicians are usually show me the fact and we'll go with that. We also support that with written policies so that not every clinician works with blood all the time. Sometimes it's not the surgeons and stuff who work with blood a lot, but sometimes our, medical providers, they don't work with blood every day. So we have these policies to help guide them and it helps give them the confidence to know use your clinical perspective and judgment on it, but treat your patient, not yourself, sort of thing. Make sure that you are doing this for the right reason. Our order sets have decisional support in them where they go to order blood, and if it falls without of our parameters, it'll kind of say like, "Do you want to do this?" It like makes them think about it a little bit. And at times the answer is yeah, I really do want to do this, and they can go on and do it. But like I said, in my role, it's really what helps us is just showing them the data because sometimes you just can't argue with the data.
In the first program that I participated in, I was not in the quality role. And so I kept showing evidence, 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 which I thought it convinced me. Why doesn't it convince the clinicians? But they can always kind of go, yeah, but that's not our patient population, or I don't know how they designed the study. But when you show them the actual data of your healthcare organization, and this is the people that they treat and their population, and you show the outcomes and the infection rates and everything that's improved by working with the patient's own blood system, it becomes real to them because it's their real data. Was there a specific case or patient that really helped this become real to you?
I can't really point to like one specific case. My role is a little bit different. I don't see specific patients, and but I think one of the once I got into this role, we didn't have a blood management program at the time. I got into it, and it was just before COVID, about a not quite a year before COVID when I got into this. And I think the COVID-19 pandemic just brought this really to mind to me because, during that there was significant blood shortages and the fragility of the blood supply became like a really possible time that we might not have enough blood to give everybody who needs it. So how do you answer that question? You just can't make more blood. When we looked at that and I understand that blood was a limited resource and it can't be manufactured, it reinforced that it's so important to optimize patients, just not during a time of shortage, but optimizing patients and identifying and treating their anemias so that they're as healthy as they can be prior to coming in even, and reducing that unnecessary transfusion. It's not only good clinical practice, but it improves patient outcomes and it minimizes transfusion related risks and ensures that we have a blood supply for those times when when blood is the answer and blood is going to be the savior at that point in time. It's not an unlimited supply. We really need to protect it.
How about you, Josh? Any particular patient case that stands out?
I do have one specific case. I was working in the ICU setting. This was in just a general ICU, but this patient came in with a diagnosis of leukemia. So she already was having very, very low counts historically. We were always fighting to keep her around 7 to 8 would be ideal for her in the situation. This patient was also a Jehovah's Witness at the same time. So when she was in the ER setting, we noticed that her hemoglobin, her blood count started to dip a little bit down below that number. But in this specific case, the leukemia was so bad that she went all the way down to a hemoglobin of 2. Now, this patient at a 2 is sitting up awake in bed and okay. And being a Jehovah's Witness, there's no option to transfusion this case. She would not accept blood. So what do we do for this patient? This is where we go even down further into like the medicine route of hemoglobin-based oxygen carriers or synthetic blood, so to speak. So we would not give her a transfusion, make sure she was doing okay. This patient went 2 weeks at a hemoglobin of 2, awake, alert, and never had deoxygenation issues with this medication, thank goodness. After being bridged with the hemoglobin-based oxygen carrier, she eventually received all of the other treatments that we have for anemias, right? Retacrit or Procrit or an erythropoietin stimulating agent, IV iron, and she went all the way back up. I discharged to 14 without a
Wow.
transfusion ever during the
Right.
admission, which is
Yeah.
phenomenal. That was the push for me. It says, if that works for her, this can work for absolutely anybody.
Yeah. I have similar story, except so my patient case is very interesting because it was actually even before I became a nurse or involved in medicine at all. When I was in my mid 20s, my father had a massive GI bleed and he was choosing not to be transfused. And that was a very scary time for me as his daughter. His hemoglobin went down to a 4. Traditional clinical people who thought, if you don't talk your dad into a blood transfusion, he's going to die. So that added a lot more fear. I wasn't medically trained, sounds great to me, but he was with a bloodless care team who felt very confident. And they were like, he's fine. I want you to look at your dad's monitors. I want you to look that he's not on oxygen right now. So yes, his hemoglobin is low. We can fix that. We have things to support his own blood and we can fix that. What is scary about his vitals right now? And there wasn't anything. And so that really helped me think, oh, this is possible. And then fast forward 20 years, I become a nurse. I find that there's an emerging medical practice called patient blood management where we're going to focus on managing the patient's own blood. And of course, I kind of wanted to be a part of that because I had witnessed it almost 20 years prior. We've had a long 5-year journey together, all three of us. We've gotten to know each other quite well, and it's because we did a monumental task. Recently, the American Nurses Association has endorsed our specialty, patient blood management nursing, as an official nursing specialty. So first of all, congratulations, guys, because I know how hard you worked on it.
Thank you. Thank you.
Same to you.
I wanted to talk to you a little bit about just our story. Josh, if you don't mind, just take me back to the beginning because I know that your mom, like you said, she was a historical, foundational person that was in this field. Give us a historical journey on this becoming a
Sure.
medical practice.
So Sherry Ozawa, who's my mother, spoke on this podcast before. Actually, you have had
Yep.
her as a guest
Yeah.
before as well. Back 20 years ago in the early 2000s, this started with the Jehovah's Witness population, this population that could not get blood transfusions due to religious reasons. And no hospitals were taking these patients. One of the local hospitals in New Jersey started the first bloodless program, so to speak. It was a team, very small team of 5 or 6 doctors and Sherry, the only nurse in that case, to create a program where these patients could get treated bloodlessly. And then that expanded, right? So that started with cardiac surgery, orthopedic surgery, GI surgery, all in this local hospital. And data started getting collected at that point. And as the data showed good outcomes for these patients who were not receiving transfusions with these major surgeries, that eventually expanded to patient blood management. Now, patient blood management now can mean a lot of different things. It's become a very multidisciplinary practice, specifically on the nursing side, which is where we did all of our work specific to make this a real specialty. There's a lot of different roles for this. And as we've started from the early 2000s all the way through now, that is constantly evolving to the point where even though we didn't have a name, we were doing all of this work for these patients. We were treating their anemia. We were watching them for blood loss. The bedside nurses were doing phenomenal work for these things. The outpatient nurses were watching these patients month to month to month as they get better or worse with whatever they had going on. So these nurses, I really had a very specialized role in these patients' lives. And that was what encouraged us as a group to finally say, hey, we're doing something different than any other nurse is doing right at this moment. This should be a specialty. So that's what the origin of this was, is this really needs to be a specialty. We're doing good work for these patients that is different from these other specialties in the way that the patient is at the center rather than a specific specialty of medicine like the heart or the kidneys or the lungs or whatever it is.
When I was transitioning into this role and kind of leaving that hands-on nursing sort of status, I had, confided in a colleague that I was concerned that I was like going to miss having that effect on patients. And she shook her head and she said, Kelly, you're a good nurse. And she said, you do make a difference every day in how you care for your patients. And she said, but this is an opportunity for you to make the difference for tens of thousands of patients to come. And it was like really profound for me when that happened. And then became involved with all of you. It just really cemented that goal to make sure that we were doing something that was meaningful and moving forward so that we can help not only our patients, but how are we going to help our patients? We're going to help our nurses understand how to advocate for them.
Let's give the audience a little bit of context here. All of us, as patient blood management nurses, were part of the SABM organization, the Society for the Advancement of Patient Blood Management. And I do want to give the committee a little bit of a shout out too, and how that formed. So Mary Ann Stromoski, which we know is also a very bold leader in patient blood management for Geisinger Health, she was leading a committee along with myself called the Resource Development Committee. And we really felt like it was time. We're like, you know what? We're large enough. We think that patient blood management should be a nursing specialty of its own. So we took that right to the board of SABM and said, we'd like to work on this project. And fortunately, the board of SABM approved it and we moved forward. Kelly, you, along with Alora Thorpe, volunteered to lead this project. That was the very first thing. We're like, we have this idea. We want to work with the ANA. We want to see if we can make this a nursing specialty. What made you say, okay, I'll try to lead it?
A glutton for punishment. I don't know. I just was, I think, I don't want to keep saying this, but I think being newer to this field, it was just the passion that everybody had. And becoming a part of SABM and listening to what they were trying, it just inspired me. I'm not sure why I was like, I want to do that, kind of
Right?
thing. In the beginning, it was just Alora and I, and it became very clear that the scope of work that this was going to have after we had met with the ANA, it became a little sobering. That the two are like, how are we going to do this and our jobs at the same time? And the level of documentation and all of that was needed. I like that about our group. Like when one of us would kind of get a little frustrated with this, everybody else sort of picked up and carried that along for a little bit until you could get another breath of air to continue with it. We just were like tenacious. We weren't going to take no for an answer. We were going to, move forward with this. And throughout the process, we welcomed the feedback that came from the ANA. They provided feedback to us. And one of the things that really struck out to me was sometimes their feedback would come back and we would realize that, okay, maybe we didn't quite get our point across. Like just by their feedback, we could see like, oh, there's just a disjointment here. And they were really receptive when we would come back and sort of sometimes we would really, push for like, this is what this means and this is why it's important. And they were great in then saying like, okay, like now we understand all of that. And Josh was really great in their communication with them and getting back to them and providing them with documentation and kind of wrapping everything up in a package. And so I think just we were the right group of people that came together at the right time. The stars aligned.
There was definitely midpoints where we thought maybe this was not going to happen. And that's when
Never.
you talked about us calling in the cavalry. We reached out and said, hey guys, we don't know if us as this committee can really get this done. We need help. And that's when Becky Rock and Josh stepped in and said, okay, we'll join the force. And they really did bring some leadership, some organization that we needed. And Josh, of course, your talent for knowing how to communicate with larger organizations and also putting together large literature and documentation is really probably what saved the day. So Josh, I'm going to ask you, what does a specialty recognition really mean, not only to us, but to patients? Why did we do all this work?
So, speaking on the topic of a specialty is pretty tough. There's the general known specialty, and then there's the recognized specialties. So, general known specialties are what you would think of cardiology, gastroenterology, neurology. When we talk about what we did as a part of our work, this is a specific nursing specialty. Now, to patients, who knows what that means, but nursing specialties in the United States and around the world, we have these designations of specific kind of pathways of care, right? So wound ostomy care nurses are a nursing specialty. Informatics nurses are a nursing specialty. And patient blood management now joins them as well. The ANA was our guiding organization, the American Nurses Association. So they have a very specific basis of what this specialty means and what we're supposed to do. That stems from defining what patient blood management is, which I'm sure this podcast has taught you much about. Where does PBM stand globally? What do we do as nurses in PBM? How does this affect people with different social settings? What are the ethics surrounding patient blood management? What's the global presence of the specialty? How does the organizations around the world support the specialty? Now, all of that is the background work for this patient, right? So this patient sees us come in and they say, what do you do for me? And it goes all the way down to the root of this specialty helps maintain the patient's blood health. And blood health of the patient is the imperative of really what pushed us forward to say, let's bring the patient in on this conversation, in addition to all of the work that we do as clinicians as well. So we've developed this scope and standards document all together that has said, here as a nurse, and with relation to your patient and how you should be caring for them, here are the things that we expect within a specialty for you to be doing. That's not just expectations, but things that you should aim to do as well moving forward.
And so let's bring this down to the listener as to like the importance of this specialty and this standard in healthcare in general. If someone is listening right now and they know they are planning for a surgery up ahead, what should change for them, Josh, because this specialty exists?
This specialty kind of gives them a framework to think around for their upcoming surgery, whatever they have going on. So let's say this patient is an orthopedic patient going in for a knee replacement, very traditional surgery. A lot of people go through it. If you're there and you're scheduled a month from now, instead of saying, oh, they can just give me a blood transfusion when I need it in the hospital, we are now stemming as nurses to help provide that feedback for the whole process, right? At the beginning, it says, oh, I'm scheduled for a surgery. What do I need to know? How is my blood counts right now? Right? That's a good starting point. So their whole framework should change around how is my blood health currently, in addition to their knee. Obviously, something terrible is going on. They have to have a knee replacement, but setting up so they have a good outcome with that as well. What are my blood levels currently? What is my hemoglobin? Is my nutrition supporting my blood health currently? Do I have any bleeding disorders that I need to be worried about? What are the things that I need to know about going into this surgery? How much blood am I going to lose? Those are all questions that weren't necessarily asked before by the patient that now are much more important, especially when you have the support of a nursing specialty behind it.
All of us have gone on a trip. But let's say we're going to go to the airport and we're going to go on a vacation and travel. Would any single one of us get on the plane if we doubted that the airplane had enough fuel to get us from our departure destination to where we decide to land?
I know I wouldn't be on that plane.
Correct. So now I think of that when we are planning for a surgery, no one really gives a lot of thought about, do I have enough fuel on board? Do I have enough oxygen carrying capacity to get me from point A and then into recovery where I want to land and where I want to be on the other side of it? And that's what patient blood management will bring to them. And now they can ask those questions. So, Kelly, maybe give some examples of like questions that patients can ask, and they should be able to expect real clinical support and answers around their blood health.
One of the first things they should ask is when they get blood results back, like, am I anemic? And what does this mean? We should treat anemia as a separate disease. It shouldn't be a symptom of something else. We should identify why we are anemic. What is the cause? What's causing it? And fix that problem first to make those patients healthier. One of the things that we're working on now is really pushing this out into our primary care offices to say when these patients are coming in for their routine physical and they're coming back slightly anemic, what are you doing about that? I had a patient who, for a couple of years, they had just sort of said, like, oh, yeah, you're just anemic, take some iron, this and that, and whatever. And when they were finally at the point where their hemoglobin came back and it was incredibly low, to that point of potentially needing a transfusion, and they started looking into the problem of it, they found a large tumor on their ovary, and their ovary had to be removed, and now they needed surgery. And it honestly, it shouldn't get to that point. We should be addressing things before it's an emergency. So we're really trying to push some of that out into our primary care office so that when you show up for your surgery that you is unplanned potentially, you're already optimized because it's just become something you go to your annual eye exam and you go to your annual stuff. We annually take a look at your anemia.
Whether you're having surgery or any hospital stay, when you're offered a blood transfusion, you should be able to ask, what else is there? What other alternatives are there? And that should be able to be answered because this specialty of patient blood management exists. Josh, do you think that there are any patient populations that this is most critical for or is going to benefit?
Absolutely. And I wanted to bring it back a little bit to what patient blood management is as a whole, right? So we know that patient blood management, what are these nurses doing? What are we doing as a nursing specialty? We're managing anemia, we're optimizing coagulation, we're minimizing blood loss, and we're keeping the patient at the center with multidisciplinary decision making with that patient as one of the members of that team, right? Now, this spans across the entire world of population. Anemia as a disease is one in three people at a baseline. You're going door walking down the street, you see one person, one in three people that you count on the street will be anemic, and they may not even know about it. And to the point that healthcare professionals aren't really explaining anemia as well. So, who's important in this case? Who's more at risk? Who do we think will end up anemic? Right? We think women's health is super important for anemia. Patients who can't receive blood, whether for religious reasons or otherwise. Cancer patients are very, very at risk as well, and older adults. I do want to focus on what's super important in those populations, not saying one population is more important than the other. Everybody is an important person, but women's health being one of the major aspects of patient blood management and nursing. And what we wanted to as a specialty is target these women who are in healthcare or going just to an appointment and they are anemic or they have a symptom and then they get dismissed, right? Dismissive medicine as a whole is a very, very bad thing. And it's plagued the healthcare system as a whole for many, many years. But with the presence of these simple things that are overlooked, like anemia, and the presence of nurses that can help bring that to more attention, now they're empowered, right? A woman who goes to their gynecological annual visit, they can say, "Oh, I'm anemic," and why is that really happening, right? There's more of a push than for women's health to ask the question and no longer have the dismissive overview or the sexist overview that has existed for so many years, to really ask the question of what's going on in my body and I want to take care of myself. Not so much on the healthcare professional side anymore, right? Patients have the role to push for themselves too, and they should. We need to, as this podcast is a great example of it as well. For any of the public that's listening, you now have the ability to push harder with the presence of a specialty like this. You can ask the questions: is what kind of questions like, what can I do for my blood that would make it healthier? What should my provider know? What can I ask my doctor? What can I do in my life to improve these things? And women's are at the really at the very center of it. Anemia for women is much, much more common than it is for men, and far more overlooked. I've one big point there as well as hemoglobin as a basis, is women will hear that their hemoglobin is normal at a 10, 11, to 12, where we shouldn't even be entertaining that thought, right? The baseline hemoglobin for all patients should be that 13 level. And without nurses behind that as a specialty, even with any healthcare professional beyond the specialty, is that push is from the public is where it needs to be, to say, my hemoglobin is low, tell me why, right? That's the
Yeah.
question that should come out.
Yep.
Josh, we should
Absolutely.
put you on a poster for women's health, okay?
I'm
Right?
ready for it.
Exactly.
Like, I'm
Yeah.
ready to hear for, we should put you on that poster for women's health because, spot on, right?
I
Yep.
appreciate it. Yeah.
Kelly, you work in quality. I work in quality. What is a sign that a hospital has a real PBM program versus a hospital that doesn't?
That's a good question. So, maybe a hospital that has a real PBM program is doing things that are proactive and not reactive. Some of the things that have done is we have developed a reflex iron panel on patients when they come in for a procedure and their preoperative labs identify that their hemoglobin is below 11. We reflex that. We want to find out why. And, it may just be your simple iron deficiency anemia, but it may not be. We've had several patients that have been on the younger side before screenings would happen, that we've wound up sending to colorectal and finding out that they had colorectal cancer that was going on. So being proactive about those things, I don't actually see actual patients, and that's because we've integrated blood management into every step along the way. I mean, we have 14 campuses, 300 outpatients in 2 states, outpatient centers in 2 states. I'm one person. I can't possibly see everybody at those things. So we've brought our pre-admission and our surgical optimization centers on board, and we've taught them patient blood management rules and guidelines and what that means and how it affects their role and what the next step is. And along the way, we've integrated patient blood management into each step of care or transition of care and what that role is responsible for doing. And I'm kind of proud of that. Initially, I think I started out looking at utilization. Like, okay, are we using less blood than we did before because of these guidelines? And that's part of it, having some guidelines to help guide you. But then what are you going to do with that data? Being that proactive rather than a reactive thing and just integrating it throughout your system.
As we wrap this up, guys, we've had a major win after a 5-year fight for sure. What do we think 5 years from now? What does success look like for us?
Speaking to that, and around the world, we kind of see it already in patient blood management in a lot of ways. And for all of these disparate specialties is being integrated well into these healthcare systems around the world. I've had the opportunity of teaching hundreds of medical students, hundreds of nursing students about this specialty and what that means. And I'm glad that nursing is the first not necessarily the first, but one of the first specialties to really be integrated into the wider healthcare system. But around the world, we see patient blood management in some very large countries start to get integrated on a national level and be regulated by law as well. And we should eventually be there as well. It's good for these patients. It's good for everybody to have somebody, even beyond just nurses, but anybody saying, oh, your blood matters and you should really care about it. So 5 years from now, what do we want? We want these legally required measures that we have in patient blood management to be integrated in these hospital systems around the country, around the world. And we have very great progress already being made internationally, which we're happy about. How do we continue moving that forward? It's with specialties like this and the recognition of nurses and doctors and perfusionists and lab techs and pharmacists and the patient to push forward and say patient blood management is really important and my blood health matters
Yeah.
and your blood
And
health
we are
matters.
Heather Mingo, who was on our group, and Becky, they're starting this with, Canada. If this can be specialized as a nursing specialty in United States, it can be specialized anywhere. And we are certainly willing to help all of that move forward. Kelly, any thoughts about what would success look like for you?
In 5 years from now, I'll be retired. So
Right.
I am of an age that I will hopefully be retired in 5 years. I will and, like, consulting from a beach somewhere, like,
Right.
that would be great for me. I have to agree with what Josh said. Nursing is one of the first, and that we have established this, and that hopefully this will grow, and this will become something that is important. To kinda say, like, well, blood flows through every department, every specialty is affected. Somehow blood affects that. So it just flows everywhere. And we need to stop the hemorrhaging. We need to make sure that we are doing everything we can throughout all of that. Hopefully, this recognition and moving forward, what might a certification look like, and those kinds of things that we go on with that. So I hope that that comes to some type of fruition before I find my beach.
Yeah, for sure.
If I want to speak more to the aspect that you were saying, Kelly, is that we want this to kind of be a second nature to the healthcare system, right? We don't want people to go and even though we're implementing and integrating patient blood management into these healthcare systems, we don't want to have somebody always be a reminder that this needs to be done, right? Think like infectious disease when really these horrible, horrible contagious illnesses were going
Mhm.
around and infectious disease became a specialty. They finally said, oh, we need to be practicing hand hygiene and doing contact precautions. And 20 years later, 25 years later, do we even think about that? We just do that. The nature of patient blood management should be the same, right? These interventions that we have for these patients, it should become second nature to say, oh, you have anemia, let's work it up. Oh, this is a high blood loss procedure, let's figure out why. We need to think at that level where it's now second nature and no longer somebody telling us to do so.
Yeah.
Eventually, as a specialty, that might make us obsolete. And I think that's
Yeah.
the goal,
That's right.
right?
Yeah.
It's okay for us to go away. It's
I'll
okay
be
for us to not
retired.
be
It's
here.
good.
Do an early retirement for all of us.
To your point, I today a patient really has to ask for an advocate for patient blood management.
That's
They
true.
have to be informed and they have to advocate. I think the highest goal for us is for that not to have to happen. Guys, thank you so much for having the conversation with me, and thank you for joining me today.
Thanks for
Thank
having
you.
us.
Thank you for having us.
Let's Talk Patient Blood Management would like to congratulate and recognize the PBM Nursing Specialty Work Group. Rebecca Rock, Joshua Ozawa-Morriello, Marianne Sromoski, Sarah Walbold, Kelly Martin, Christine Cahill, Heather Mingo, Alora Thorpe, Deborah Tolick, and Sherry Ozawa.